So welcome all of you for this quiz, which is the annual program which we conduct at MedEClasses. This is the second version. And we got participants from across the globe, from around 20 countries who participated both for basic and advanced one. Our website, learning.growsociety.in, which provides a lot of information about pediatric endocrinology, various aspects and practical tools as well. We've got specific training programs in the form of fellowship and diploma programs. We have got a lot of our webinars which happen, including the postgraduate lecture series and the other scenarios which are discussed. Our publications are there and the mobile applications are there in that regard. So MedEClasses quiz, basically we had got two sections we did this time, both for basic as well as advanced. The basic one was mainly for postgraduates and pediatricians, while the advanced was more for people who are doing DM or they are doing fellowship or they are pediatric endocrinologists. We've got 6 participants there: Dr. Arun George, Dr. Reshma, Dr. Aniket, Dr. Guru Prasad, Dr. Manoj, and Dr. Sumaya. So by the time Dr. Guru Prasad joins in, we will start off the quiz and we will run in a sequence of Dr. Manoj, followed by Dr. Aniket, followed by Dr. Reshma, Dr. Sumaya, and Dr. Arun George. And then finally, we have got Dr. Guru Prasad, who has also joined in the quiz in that regard. So the rules are and the prices are: the first prize is a subscription to the advanced pediatric endocrine course. The second prize is a subscription to the basic pediatric endocrine course. And then we have all the finalists will already get a complimentary subscription for the adolescent endocrinology along with the mobile application which is there. We will have 4 direct and 1 buzzer round, 10 marks for direct and 5 for pass, 15 seconds to answer. As Dr. Samar was saying, we may give a bit more time, so don't hurry up, but think properly. And again, quiz master's decision is final, so we won't take any other references. We'll just decide because we don't have that much time to discuss as well. So we'll start off with the first round. This will be the spot the diagnosis round. And the first question will go to Dr. Manoj, and then we'll go into this sequence, and the second round will go in the opposite sequence. So Dr. Manoj, your question is: 7-day-old neonate with irritability. He had hyperglycemia and phosphorus was low. PTH level was high. So he was initially managed with hydration and diuretics, and the treating team thought that we should go for surgery. Now, over time, over the next few weeks, he had a milder form of hypercalcemia, which basically improved over time. And so somehow from severe hypercalcemia, this child went up to a milder hypercalcemia without any surgery. Now, what do you think would be the explanation of this case? So it's a bit of a thought process you think about it. Yeah.
Maybe calcium sensing receptor defect causing familial hypocalciuric hypercalcemia.
Yes. So this is a homozygous or a heterozygous?
Sir, it's a homozygous mutation. So he improved with the hydration. Sir. So usually they will be asymptomatic. So they improve with the hydration.
No, so what I'm saying that this, if you're talking about homozygous, they usually are very severe. They don't improve at all. They would need surgery usually. So this case looked like a surgical case, but then improved. Even after hydration, he became normal. So they
maybe a carrier.
So I'll go for the next person to see if we have a better answer. Dr. Reshma.
Sir, actually, this child has inherited a CSR defect from the father. So he sensed his mother's calcium as low, and that is why he had a transient hypercalcemia.
That's a perfect answer I was looking at, because normally if we talk about homozygous forms, it will be very, very severe. And otherwise, you will have a problem which will happen from that perspective, and there will be a problem in that regards. So that was the first question which was there. So 5 marks to Dr. Reshma for the pass in that regards. Now the next question is directly. So this was a paternal calcium sensing receptor defect. The child is sensing mother's calcium, which is normal, as low, and then it causes hypercalcemia, which improves. Now second question is directly to Dr. Reshma. The question is: 9-year-old boy with short stature, very short, minus 3.4 SDS. Normal screening investigations, low growth hormone, normal MRI initially. He had a good response to GH. So this is a very early onset GHD. We're looking mostly like a congenital growth hormone deficiency. On follow-up, initially he did not have deficiencies of other hormones, ACTH and TSH, but later on they developed. So people thought this could be a new tumor or something. So MRI was normal. What is the most likely cause? So isolated GHD progressing into a multiple pituitary hormone deficiency.
So this can be a genetic defect like PROP1 mutation, which after GH, ACTH and TSH later on develops.
Okay, anybody else, if they give a better answer, I'll take it. Otherwise, I'll give it to you. So Dr.
PIT or
Somaya?
PROP, sir. PIT or PROP. POF1 or...
I get your point. I get your point. But there is a more specific answer also, option which I'm looking at. If we don't get it, we'll give you the points. Dr. Somaya, do you have any better explanation on that? You're muted. You're muted.
POF1, sir.
PROP1. Okay, Dr. Aniket?
Yeah, I think it is POU1, F1 or earlier markers rather than PROP1, because PROP1 generally has very less chances of ACTH deficiency.
Okay, Dr. Arun?
It's probably PROP1, but the secondary, the defects of ACTH and TSH could be because of the mass effect, because of a mass lesion which develops later.
Okay, but MRI was normal. So anyway, yeah, Dr. Guru Prasad, any alternate answers you want to have?
No, sir. PROP1, I feel.
Okay, yeah. And finally, Dr. Reddy?
No, sir. No.
Okay. So actually what I was looking at, PROP1 is of course possible that you can have evolving deficiencies, but one condition which specifically presents like this is a scenario of autosomal dominant form of GHD in which the splicing defect is there. And because of that splicing defects, first you have isolated GHD which develops into a MPHD. But I agree, PROP1 can also cause that. So we'll give 10 marks to Dr. Reshma there. So the next question is to Dr. I think the sequence is Somaya. So Dr. Somaya, your next question is 3-year-old boy with short stature, very short, basal growth hormone is 24, IGF-1 is low, had a normal birth weight. There was no increase in IGF-1 post-GH. So I'm asking for which biochemical test will give you a genetic diagnosis. You're doing a biochemical test which is giving you a diagnosis.
So this looks like Laron syndrome, growth hormone resistance. So IGF-1 generation test can be done.
No, we have done that already. So IGF-1 generation test is already there. This is growth hormone insensitivity. If we did a biochemical test which gave you a diagnosis that this is the genetic defect. So this defect could be at multiple levels, growth hormone receptor, IGF-1, whatever. So this single test gave you a diagnosis. So I want that specific test.
IGF-BP3.
No, we'll go forward. We'll go to Dr. Aniket.
ALS?
ALS, no. Dr. Arun?
Growth hormone antibody to the growth hormone receptor.
No. Dr. Guru Prasad?
No, sir. Pass.
And Dr. Reddy?
No, sir. Pass.
Dr. Reshma?
Pass.
Okay, so this was a trick question actually. This is a growth hormone binding protein. So growth hormone binding protein, if there is a defect, that is an extracellular domain of the growth hormone receptor. So that's a very specific, if GHBP level is low, you will get the diagnosis. So that will, no one will get the answer on that one. Correct answer, it was a bit tricky. So GHBP would be the one which is significant. The next question is to Dr. Aniket. And Dr. Aniket, your question is, a 2-week-old boy with micropenis and hypoglycemia, cortisol is low, sodium is low, potassium is marginally high, ACTH is high, and you can see the picture. You have to focus on one particular part, but I will not go into that. Which routine lab test will give you the diagnosis? So hypoglycemia, hyponatremia, low cortisol, high ACTH. So primary adrenal insufficiency. This clinical picture is giving you a clue, and you want to do a simple test. You'll get the result in 1 hour and you will know the diagnosis.
For whom to answer, sir?
No, Dr. Aniket. Dr. Aniket. Dr. Aniket?
Ketone?
ketone levels are will not give you the diagnosis. So we will go ahead with the second one. This is a ketotic hypoglycemia anyway. So the next person there would be Dr. Arun. Yeah.
So I would do a lipid profile.
Yes.
For Smith-Lemli-Opitz syndrome.
So what are you finding here? Although it's not, he's already on a tube or something, but there is a specific feature. There is already micropenis, which is there. There is also an upturn near, which is there, which is very characteristic of that. So anyway, hyponatremia with, you have to think of a SLO. So correct answer there. So 5 points to Dr. Arun, that is there. The next question is to Dr. Guru Prasad. Direct question. So next question is to Dr. Arun, sorry. So next question directly to Dr. Arun. 10-day-old child with hypoglycemia. GIR is 14. Ketone is 0.2. Insulin is 2.4. Detectable insulin, non-ketotic. No response to diazoxide. Somebody ordered a genetic test. Which of the genetic tests suggest a focal form of hyperinsulinism?
Focal form will be an autosomal recessive mutation of the
recessive or dominant, or coming from which?
This will be a autosomal recessive one. However, it will be not in the
so this is a hyperinsulinism. The question is which form suggests a focal hyperinsulinism? Final answer, Dr. Arun?
It will be a autosomal recessive, either ABC potassium channel mutation, but affecting
Okay,
the
we'll take the second one. Dr. Guru Prasad?
So it is autosomal recessive from the paternal inheritance.
Paternal inheritance, so autosomal recessive. You are right. Paternally inherited defects are suggestive of a focal form of hyperinsulinism. So you do a rapid test for the potassium channel defect. If it is coming from the father, it suggests that you have there's a focal form. So I think 5 marks to Dr. Guru Prasad. It will be autosomal dominant, but the paternal approach is coming from paternal has to be autosomal dominant. If you have a recessive, this will be a diffuse disease usually. Yeah, so then you will go for dopapet. So the answer, I was looking for a paternal defect. So he was more specific, I would say. So I'll give 5 marks to that. So I think we'll go to the next question to Dr. Guru Prasad. Direct question to you. I think this is the final question of this round. 6-year-old girl with obesity with night blindness. And this is the picture. What is the mode of inheritance of this disease?
So this is Lawrence Moon Bardet-Biedl syndrome.
Yeah.
Polydactyly.
Yeah. Mode of inheritance. So there'll be no marks for the diagnosis because that's very evident.
Yeah. So this is autosomal recessive.
Okay, no. Dr. Manoj?
Autosomal dominant, sir.
Dr. Aniket?
Sir, excellent.
So I think all sort of inheritance have been gone. So Dr. Arun and Dr. Reshma?
Genomic imprinting, sir. Bardet-Biedl is an imprinting disorder.
Dr. Arun George? So I think we have exhausted pretty much.
Ciliopathy, sir, ciliopathy.
Yeah, it is a ciliopathy, but what is the mode of inheritance?
Somatic.
Dr. Sumaya, final answer?
Sporadic.
So I think the only one which was not mentioned is a oligogenic inheritance. So this is a specific case of oligogenic inheritance in which many genes combine to give a picture. So Kalaman, some of these hypogonadotropic hypogonadism, and these ones are the oligogenic inheritance. So this was a trick question there, but I think it was a tough one as well. So what is the score at the end of round 1, Dr. Vibha? We have got Dr. Arun George at 5, Dr. Reshma at 15, Dr. Guru Prasad at 10, and others have to open accounts. So I think big round of applause. This is just the beginning. A lot of questions are going to come. So all of you can do well subsequently. We will have a specific question now for the audience. So this you can use the chat option or the Q&A. So first for the audience who are there across the globe, and then from the local audience, we will ask if nobody answers from there. 14-year-old girl with tall stature, height is 173. There is arachnodactyly. There is an upward lens dislocation. There is pectus. Which acute emergency is likely in this girl with tall stature and upward lens dislocation? Very specific question. So we'll see. So aortic dissection, Dr. Samvar has already mentioned. So I think the quiz people, please don't write the answers. This is more for the audience. We'll see. So aortic dissection, the first answer had come. Already people were writing here very quickly. Dr. Kompal Paharia, first answer. So again, that's a right answer. So we already started with the first round. We'll now move forward towards the second round. And the second round is about imaging. So these will all be imaging based. So good that we did not have the class on imaging today. So it would have been unfair for Dr. Guru Prasad. So I think this will be the round and we'll go from the backward. So we'll start with Dr. Guru Prasad right away. I would need the sequence because the sequence is here is a bit different. So we'll start with Dr. Guru Prasad. Your direct question is this. You see this image. You have to tell me what is the most common endocrine manifestation of this disorder. This pituitary imaging. You are seeing something. I want to know what is the most common endocrine manifestation. Of course, you have to tell what are you seeing, but you won't get marks. You may get half marks if nobody else tells us, but you have to tell me what is the most common endocrine manifestation of this disorder.
Is there a germinoma with diabetes insipidus?
No. The next one will go to Dr. Arun. Dr. Arun?
Is it a Rathke cyst with growth hormone deficiency?
No. The next one will be Dr. Aniket.
Is it a midline defect? Septoplastia like?
No. Then we have got Dr. Sumaya.
It's an arachnoid cyst.
Yes.
Most common manifestation is precocious puberty.
Absolutely right. I think that's a very good answer. So it's an arachnoid cyst, and you can see the cyst which is located in this area. It's a CSF collection which is there, and this is the most commonly causes precocious puberty. So perfect answer, 5 marks to Dr. Sumaya. The next direct question is going to Dr. Arun George. And Dr. Arun, your direct question is again, since this is an imaging round, 14-year-old boy with headache and short stature. This was the MRI picture, and a very simple test made the diagnosis. So what is the test which will make the diagnosis in this case? Dr. Arun? Dr. Arun, are you there?
Yes.
So what do you think is there?
There is a suprasellar mass.
Okay. So we'll move forward to the second person, Dr. Aniket.
Sir, is it a prolactinoma? Prolactin?
It's not a mass. So I'll give an option to both of you. It's not a mass. It's something else. It is reported as a mass, but it's not a mass. So we can go back to Dr. Arun first then, because I'll give a hint to everybody. People say this is a mass, but this is not a mass.
I would do a thyroid function test.
Okay.
Because hypothyroidism can have a secondarily have a mass like it.
So this is often labeled as a pituitary mass. This is pituitary hyperplasia. It's a diffuse pituitary hyperplasia. So I think that's a good answer. So 10 marks, Dr. Arun, for that. So that will be 10 marks to Dr. Arun. The next person would be Dr. Aniket, who will be getting this direct question. 8-year-old girl with severe short stature. This is the finding. You have to tell me the finding and also the most common endocrine defect that you see.
Sir, is this an interrupted pituitary stalk with
Yes, yes. So this is interrupted pituitary stalk. You have hypoplastic anterior pituitary. The posterior pituitary is ectopic. There is no stalk.
Ectopic, yeah.
Yes.
Yes,
So
sir.
PSIS, what is the most common endocrine defect?
I think growth hormone deficiency is the most
Yes.
common.
So 10 marks there. So again, the right answer from Dr. Aniket. The next question will go to Dr. Somaya. Your question is this 14-year-old boy with headache, and this is the MRI which is there. Now the endocrinopathy, which will tell you what is the site of the defect. The presence of which endocrine disorder will tell you where is the defect or where is it coming from.
Diabetes insipidus,
Yes.
suprasellar mass, so,
Yeah, so
craniopharyngioma.
yeah, absolutely. This looks like a craniopharyngioma, and if you have a DI in this scenario, that will pretty much give the diagnosis. So very good. So you are excellent in neuroradiology, I would say. So I think 10 marks for Somaya again. The next question will go to Dr. Reshma, a direct question. This is a 12-year-old girl with thyroid nodule. Now TSH is normal. The image looks a bit blurred. I think it has got a lot of calcification. So it's a multiple calcifications. What is the likely risk of malignancy if you have ultrasound like this? How much percentage? I want broad percentages. Dr. Reshma?
Sir, with microcalcifications, risk of malignancy is less. So I will go for 10%, sir.
These are multiple ones actually. So these are one of the higher end. Okay, we'll get the other numbers first. So we'll go forward to Dr. Reddy. What do you think?
It is looking multiple calcifications along with solid areas more. So malignancy risk is more, maybe around 40%.
40%. We'll go further. We'll take other guesses as well. So the next would be Dr. Guru Prasad.
So the microcalcification, the risk is almost 75 to 90%. Papillary carcinoma.
It's actually a very, very high risk scenario. There's multiple and foiled areas, so the risk will be very high. So it will be like 79. This is the highest end of risk as far as this is concerned. So correct answer, Dr. Guru Prasad. 5 marks for that on that perspective. So we will move forward. I think the last one to Dr. Reddy directly, the direct question. This is the 6-year-old girl with Cushing syndrome. Low dose dexamethasone suppression test did not suppress. Urinary free cortisol very high. ACTH undetectable. This is the adrenal CT. Now, this is a trick question. Which dynamic test would give you a diagnosis? So first of all, you make the diagnosis. What do you think of? And which dynamic test will have a funny result which will give you the diagnosis? It's a bit tricky, but I think if you think over, you will get the diagnosis.
Sir, it may be macronodular adrenal hyperplasia, and doing HDDST, the cortisol may rise in spite of
paradoxical rise in cortisol. So I think that's a absolutely right answer. So we'll give you the marks on that. So paradoxical rise will be relevant. So 10 marks to Dr. Reddy on that perspective. So while we compile the score, we have got the next set of audience question, which is coming up. 3-year-old boy with polyuria. This is the easy one. Urinary osmolality was low. Sodium was high. After DDAVP, the urinary osmolality increased. Diagnosis established by examination. So what examination finding made the diagnosis? So we'll see if somebody has written the answer. So what finding? LCH has already been mentioned. LCH, seborrhea. So the correct answer is seborrhea by Arjun. So Dr. Arjun will the right answer on that. There are 2 LCH, but I'll take the seborrhea the right answer in that perspective. So this is histiocytosis, seborrhea or rash or whatever will be the scenario. So at the end of round 2, we have got Dr. Arun George, Dr. Reshma, Dr. Somaya, all at 15 points. And we have got Dr. Aniket, Dr. Guru Prasad, and Dr. Reddy at 10 points. So it's a very, very close knit contest. So we've ended 2 rounds. We'll go forward to the 3rd round now. And we will again now go forward from Dr. Reddy to start off with. This is going to be a diagnostic dilemma. So these questions will be about diagnostic dilemmas. So the first question to Dr. Reddy is 6-year-old boy, tendon, xanthelismas were there, xanthomas, very high level of LDL cholesterol, started on statin and ezetimibe. And suddenly the parents complained that he was having syncope and he was having giddiness, syncope, postural hypertension. What is the likely diagnosis and what test will you do to identify the cause? So this is familial hypercholesterolemia.
Hypercholesterolemia. So LDL receptor defect may be the cause.
No, I'm
this-
asking, yeah, so this is very obviously, this is a LDL receptor problem. I'm specifically asking the cause of syncope.
Maybe atherosclerotic plaques in carotids can cause.
Okay, anything
Or
else?
in-
I'll take another, I'll come back to you, but there are other more better explanations which are also there. So we'll come to Dr. Reshma. So a child with familial hypercholesterolemia with syncope. Anything to look at specifically?
Sir, I will, sir, clinical examination, are you meaning, or biochemical
No,
test?
clinical, biochemical, imaging, more of biochemical or imaging, I would say.
Sir, I would like to do a ECG,
Okay, for?
sir, to see for any rhythm abnormality.
Okay, anyway, so we'll go forward then. Next to Dr. Somaya.
So transient ischemic attack.
Okay, so again, more like atherosclerosis, but I'm looking for a very specific, there is a specific cause. If not, I'll give it to atherosclerosis because that's a obvious explanation. Dr. Aniket, a child with hypercholesterolemia having syncope.
Sir, 2D echo to see any aortic outlet obstruction. Or...
Yes. So this is very important because aortic stenosis is very, very common in this scenario. So we anyway routinely say that you should do an echo. So in this scenario, you should definitely do an echo. So very perfect answer, Dr. Aniket. 5 marks for the pass from there. Now we will have the next question, which will go to Dr. Reshma. The question is 16-year-old girl with amenorrhea. FT4 is low, TSH is normal, MRI is normal, cortisol is normal. So it was diagnosed as central hypothyroidism. And she was started on thyroxine. After follow-up, 4-6 weeks later, the TSH has gone up. So what is this explanation of somebody who was looking like a central hypothyroidism? Now suddenly you see the TSH has gone up. So what is wrong? What is your likely explanation? Maybe you don't need to think of disease. Something else may also explain this.
So this is probably a laboratory error, sir. Maybe the assay they have used different.
So assay different. Any specific type of laboratory error which can explain this?
So the heterophile antibodies can
Absolutely.
cause.
So that's a perfect answer for that. So I was looking for heterophile antibodies. That's why you have different answers. You have you found low levels and now the levels are high. So this was actually a lab error which was there. So again, 10 marks to Dr. Reshma at that. The next question will go to Dr. Sumaya. And the question there is, again, 16-year-old girl referred to you as thyrotoxicosis. FT4 is very high. TSH is very low. There are no clinical features, no goiter, no tachycardia, no tremor. No, the treating physician said that there seems to be a drug which has caused this result, and he was right. So which drug can cause this sort of a bizarre thyroid profile?
Sir, apart from levothyroxine, sir.
Yeah, so levothyroxine, you will have clinical features anyway for thyrotoxicosis. Yeah.
Okay. Anti-epileptic, sir.
Anti-epileptics. We'll go to the next person, Dr. Aniket.
Is it amiodarone can lead to such picture?
So I think all of them will have clinical features. What I'm saying is that this child has no clinical features. And so there is a biochemical error. You can say there's a lab error, of course. So which drug is causing this? So we'll move forward to Dr. George, Dr. Arun. Which drug caused this?
Valproate.
No, we'll go quickly. Dr. Guru Prasad.
So heparin?
Heparin will not cause this picture. You can have a high FT4, but that's a different thing altogether. Then we will go to Dr. Manoj.
Sir, biotin.
Biotin. So this is a perfect answer I was looking for. This is a biotin which can cause, because it's a biotin related product, and biotin can cause this biochemical thyrotoxicosis, which is not there from that regard. So this again, the answer is biotin. So there will be 5 marks to Dr. Manoj. Now we will move forward to the next question, will be to Dr. Aniket directly. Dr. Aniket, your question is 16-year-old girl with galactorrhea Prolactin was reported at 16. She developed headache and vomiting. Somebody did an MRI, it showed a large adenoma. After dilution, sample was 1000. So we know the answer. This is a case of hook effect in which you have got a very high level of prolactin. All you have to say is, tell me 2 more hormones which are affected by a hook effect. So we are continuing this lab errors. So 2 more hormones other than the prolactin which are affected with hook effect. Dr. Aniket?
Yes, sir. 2 more hormones. Is it TSH can have this problem?
And so I would specifically want to have 2 because
okay, yes.
So Dr. Arun? Dr. Arun?
One is TSH and other one testosterone.
No. Dr. Guru Prasad?
ACTH, sir.
ACTH, no. Dr. Manoj?
Calcitonin.
Calcitonin and TSH. Anything else? If you add 1 more, I'll give you full marks. Otherwise, because TSH was already there.
No, sir. ACTH I also wanted to add, but
okay.
As I said, no.
Yeah. So anybody else would like to add? Dr. Reshma? So TSH and calcitonin. So I think we'll give.
So,
yeah, Dr.
Gonadotropins.
No. Dr. Somaya?
AMH, sir.
No. So generally, those tumor markers, so all these tumor markers like HCG, those levels which go very, very high will cause this. So HCG, TSH and calcitonin. So Dr. Aniket gave TSH and Dr. Manoj gave calcitonin. So we'll give half marks to them, 5 marks, because it was a tough question. So 5 marks each to both of them. So now we have a direct question for Dr. Arun. So Dr. Arun, your question is, 16-year-old girl with hirsutism. She had amenorrhea for 3 months. There was no obesity or galactorrhea. Testosterone level was high. Her 17-OHP was slightly elevated, but her ACTH level was normal. So there was a falsely positive 17-OHP level. So the question again, think of falsely positive 17-OHP level. It is an amenorrheic girl. Which test should have been done which could have avoided this misdiagnosis? Dr. Arun.
Like elevated progesterone can cause a falsely elevated 17-OHP.
Yes. So this is a very, very right answer. So basically, usually we want to do 17-OHP in the follicular phase. But if you do in somebody who is amenorrheic, you don't know whether they are going to ovulate or not, you do a progesterone. So the right answer is progesterone. Absolutely right. So 10 marks will go to Dr. Arun for that. The last question in this one would be going to Dr. Guru Prasad. And your question would basically be a 15-year-old girl with obesity. There is no clinical features of Cushing syndrome. Somebody did a overnight suppression, which was found to be non-suppressed. So you had diagnosed as Cushing syndrome. Urine-free cortisol was normal because you doubted it to be Cushing syndrome. Which drug that the child could have been taking could have caused this clinical picture? So which drug would have caused a falsely positive ONDST while UFC is negative?
Oral contraceptive drugs, sir.
Oral contraceptive drugs would basically cause what? You will have a high
increases
level
the cortical CBG, cortical blinding globulin, and hence it will increase the cortisol.
So we will take the answer for that 10. So OCPs, or if you are somebody is on phenytoin or any enzyme stimulating drugs also, you will have this false negative, false positive overnight dexamethasone suppression. So I think this is the quiz. So now, while we compile the question, we'll have the audience question. And again, you can write on the Q&A. The question is, 14-year-old boy with gynecomastia. You have got stage 2 breast. Testicular volume is normal. Pubic hair is stage 3. LH, FSH and testosterone is normal. Prolactin is 120. MRI is normal. So again, we are continuing with the lab test. So what would you do in this scenario? So a child who has gynecomastia, normal LH, FSH, testosterone, prolactin is high. MRI is normal. So people are talking about prolactin in dilution. So MRI is prolactin is already high. So by diluting, it won't help out. Anything else? Audience here? No. So you have got a falsely elevated prolactin. What will you do? No? Manoj?
Macroprolactin.
So this is a macroprolactin. And of course, you will need to do a pegylation study. So the MRI is normal. So this is not a prolactinoma. It's basically because of pegylated. So Dr. Rashi has given the right answer. Dr. Rashi Agarwal from Amrita Institute has given the right answer. So this was a very interesting third round. Before we head towards the final round, let's go to the, again, it's a very neck to neck going on. 25 marks each for Dr. Arun and Dr. Reshma. 20 each for Dr. Aniket, Dr. Guru Prasad, and Dr. Manoj, and 15 to Dr. Somaya. So it's a very neck-to-neck fight going on. So let's see what happens in the fourth round before we go ahead for the buzzer on that. So the fourth round is therapeutic dilemma. So this is about questions, what sort of treatment should be given and what should not be given. So we will again go in a reverse order. Dr. Guru Prasad, this will be your direct question. Your question is, 12-year-old girl with hyperglycemia, sugar is 220, there is HbA1c is high, there is developmental delay, deafness, and recurrent stroke. Which drug you should not use? I think this is an easy question. Dr. Guru Prasad? 12-year-old girl with hyperglycemia, multiple things happening, developmental delay, deafness, stroke. Which drug should not be taken? So your answer, Dr. Guru Prasad?
Pass, sir.
Pass. Okay, so we will go back to Dr. Arun.
Diagnosis DENT syndrome and drug contraindicated would be
so we'll go forward.
sulfonylureas.
So diagnosis is wrong. So we'll go forward. Aniket, Dr. Aniket?
Yes, sir. Probably this is melas and metformin should be avoided.
So I think that's a perfect answer. This is a mitochondrial form of diabetes and metformin should be contraindicated. So 5 marks directly to Dr. Aniket. The next question is directly to Dr. Arun George. And Dr. Arun, your question is 17-year-old girl with delayed puberty. Now listen carefully. It's a bit of a tricky question at the end. Stage 1 breast development, stage 1 pubic hair. So delayed puberty, no breast, no pubic hair, normal height, hypertension, and there is a high FSH. There is no palpable gonad. Now the question is, what is the most effective therapy for her hypertension? So there is hypertension with delayed puberty, most effective therapy for hypertension.
So this child has like high FSH, probably Turner syndrome. So most effective therapy would be correction of the coarctation.
Okay, we will move a bit forward. Let's see what other people are saying. Dr. Aniket?
Yes, sir. I think this is 17-alpha hydroxylase deficiency of CH.
Yeah.
And so replacement of cortisol, CH.
Absolutely. So this was a trick question. The severity of hypertension is too much. Height is also 154. So we tried to keep Turner's as less likely. So this was 17 hydroxylase, and then hydrocort will be the best option. So I think again, good big round of applause to Dr. Aniket. 5 marks for pass. Now you have a direct question, Dr. Aniket, coming up for you. Your direct question is 4-week-old girl with refractory hypoglycemia. Ketones are negative. Insulin is high. No response to diazoxide. Dopa PET did not show a focal lesion. Which immunomodulator has been used in this scenario? So I think this is a straightforward one, if you know it here.
Yeah, sirolimus.
Sirolimus. So absolutely right. So 10 marks to Dr. Aniket. So Dr. Aniket has had this late surge. So he's having this log overs going on now. So we'll move forward. Next would be to Dr. Somaya. And Dr. Somaya, your direct question is 2-week-old girl with failure to thrive Blood sugar is 420, no ketosis. Birth weight was normal. There were ear creases. And then at 2 months, this diabetes went off. Now this girl comes back to you again at 13 years with again diabetes. So what is the effective treatment in this scenario? So neonatal diabetes, resolved, recurrence. Now what do you treat? Dr. Somaya?
This is probably Beckwith treatment. No, okay. Metformin, sir.
No. So we will go forward. Dr. Reshma?
So this was a transient diabetes mellitus involving the ZAG or PLAG. So, sir, here sulfonylureas we will give a try.
Absolutely. Very good answer. This is a transient diabetes. And this ear creases is not because of Beckwith treatment, but because of other imprinting disorders. And then recurrence is treated via this sulfonylurea. Very good response. So again, 5 marks to Dr. Reshma. Now we'll go to the direct question, which is there for Dr. Reshma. 6-week-old girl with failure to thrive. Sodium is 120, potassium is 6.8, hyponatremia, hyperkalemia, normal 17 OHP, high renin, high aldosterone, ultrasound normal. So this looks like a pseudo-hypoaldosteronism. I think diagnosis is very easy. The next part is a bit confusing. Which antibiotic has been used? Some people still use it as a treatment for this condition. So, which antibiotic has been used?
So blind guess, sir. Aminoglycoside.
No. We'll go forward to then Dr. Reddy. So it's a tough one. If you know that's that sort of a thing here.
Trimetrin.
Trimetrin, no. Dr. Guru Prasad?
Is it trimethoprim? Sulfamethoxazole?
You are closer, but no, not yet. Then we have got Dr. Arun.
Just a blind guess. Penicillin.
Okay, we'll come back and see if that will be awarded or not. Dr. Aniket?
Is it nitrofurantoin?
No. And now I think we'll go to Dr. Somaya. I think this was a...
Chloramphenicol also.
No.
Chloramphenicol.
We got pretty much all the antibiotics done. So this is an interesting scenario. Carbenoxolone is basically being used wherein you will have the conversion. It will have a 11 beta HSD inhibitor, which will inhibit 11 beta HSD, and this cortisol will then start acting on the mineralocorticoid receptor. So you're doing the opposite of AME. So this is, I won't give the answer to that. So this is the scenario, but some people use it still. The treatment of choice is high dose fludrocortisone that we use along with sodium chloride and 3% saline. So I think the last question, which is in this round, will go to Dr. Manoj. 14-year-old boy with bipolar disorder on lithium and SSRI, polyuria dehydration, serum sodium is high, urinary osmolality is low. So this is DI, no AVP response. Which is the treatment of choice? And I want a specific one drug only.
It's a nephrogenic DI, sir. Thiazide diuretic, hydrochlorothiazide can be given.
Okay, let's go see if we have a better option for this particular condition. Dr. Guru Prasad?
Sir, lithium induced is always amiloride should be used. It's a drug of choice.
Yes, so for lithium, it's the amiloride. So generally for NDI, we talk about thiazide, but for this particular condition, it is the amiloride which is there. So 5 marks to Dr. Guru Prasad. So I think this was a very interesting round, and we will compile the score. Meanwhile, we have got the final audience question which is coming in. The question is, 2-week preterm neonate has hypercalcemia, phosphorus is 1.8, PTH is low, vitamin D is low, and calcitriol is high. What will be the correct therapeutic strategy to prevent this hypercalcemia from happening? Let's see if we have any Q&A answers coming in. Fat necrosis, no, this was a different scenario. So you have got a 2-week preterm neonate. I'll say he's on TPN, and you're getting this picture. So anybody from here? So phosphorus is low. This low phosphorus is causing 1-alpha hydroxylase and hypercalcemia. So this is what we are looking at. Magnesium, IV calcium, phosphate. Dr. Kompal. So I think Dr. Kompal is the maximum scores that she is giving a very good answer from there. So this was the round. Direct rounds are over now. Dr. Aniket had a late surge of 40 marks. So he's really going up in terms of the lead, but it's very narrow. Dr. Reshma is at 30. Dr. Arun George and Dr. Guru Prasad are at 25. Dr. Manoj is at 20. And Dr. Somaya is 15. So all of them are in a reachable range. And we saw what can happen if you do too much also, you may lose. If you do too little also, you can use. So it's a bit of a problem issue in terms of the buzzer. The chart will be reset after every question. I'll write N and then you have to write Y. The first one to write Y will immediately be asked the question. We'll stop there. There'll be no pass, no time to discuss. So think before. Plus 10 for a correct and minus 10 for the wrong answer. So be careful. The total difference is 25 marks. So lowest can become the highest also here if you answer the 6 questions correctly. So I'm resetting it now. And we have the first question coming on in this scenario. The first question is 12-year-old boy with rickets. And this is a picture. You have got low phosphorus, no metabolic acidosis. Dr. Somaya has already answered. What is the advantage of novel therapy? You have to tell me the advantage of the new therapy. First of all, what is the new therapy and what is its advantage? Dr. Somaya?
Sir, can you hear me, sir?
Yeah, now.
Yes, sir. It's new. This is hypophosphatemic rickets.
Yeah,
so the new therapy is burosumab, which is a monoclonal antibody against FGF23.
Yeah. And the advantage?
So it directly acts at the level of the FGF23. So
what is the adverse effect which doesn't happen, which we had with conventional therapy? Effect on which organ?
Renal.
So nephrocalcinosis will not happen, less hypercalciuria. So we'll give you 10 points on that. So this was a perfectly right answer by Dr. Somaya. So 10 marks. This is hypophosphatemic ricket, burosumab, and you get less hypercalciuria. I am resetting again. The next question is 5-year-old girl with lipemic serum, very high triglyceride. Dr. Arun George, gene therapy. Which therapy? Name the therapy. You have to give me the specific name of the therapy.
This is familial hypertriglyceridemia. So the
which can cure the disease.
Lipid can be done.
No, that will not cure the disease. So the answer I was looking for was a specific therapy, Glybera, which is a treatment which was given for gene therapy. It's a very expensive therapy. So unfortunately, that will not be accepted. So minus 10 there for Dr. Arun. This one, I think, may be a one which is easy. Which treatment has recently been approved? So the first one to go on this one is Dr. Aniket.
Sir, this is
the condition is?
Condition is again the hypophosphatemic rickets.
Hypophosphatemic rickets, okay. I think we'll now, because there's no pass here, we will ask the audience here, what do you think the diagnosis is? Hypochondroplasia, achondroplasia, and the treatment is vosoritide. Right. So that will be minus 10 then for Dr. Aniket. So look into the question carefully, I think, before you go ahead. So we now have got only 3 questions, I think, remaining. Vosoritide will be the CNP receptor agonist. Next question, I've reset the button. 13-year-old girl, GHD, advised growth hormone. Now, the question is, which long-acting growth hormone acts to increasing albumin binding? Dr. Somaya.
So, Lonapeg somatropin.
Lonapeg, that increases the albumin binding.
Sir, somatrogon.
No, the answer is somapacitan. So, minus 10. So, that is there are different mechanisms by which it works. So, it will be somapacitan, minus 10 there. So we'll again reset. Now we have got only 2 questions left. What is the current score? Dr. Reshma and Dr. Aniket were tied at 30. Dr. Guru Prasad is at 25. Dr. Manoj is at 20. Dr. Arun is 15. And Dr. Somaya is 15. So again, it's a very, very tight race. Still, this 15 can take 2 questions and they'll be 35. So we can still go for the last ball. 6 can be there. A possibility is there. So I'm going to reset it again. And the last 2 questions. So this question is coming now. 4-year-old boy with rapid growth. Height is there. So we already got the answer. Dr. Reshma has said, now what is the mode of inheritance?
Sir, this is Beckwith-Wiedemann. It is an imprinting disorder.
So I think this time we've got the absolute right imprinting. So we've got 10 marks, Dr. Reshma. So good. So what is the score now?
10 marks, then she was 40 highest. And next is Dr. Aniket 30 and 25 Dr. Guru Prasad and Dr. Manoj 15, Dr. Arun and Dr. Sunil.
So this question is for Dr. Aniket to take those 10 marks. Otherwise, Dr. Reshma is going to be winning anyway. So this is going to be a very tough fight. Let's see what happens. So we will put it the reset. And the question is this. 3-year-old girl with rapid weight gain. Dr. Aniket has already said. So you give me the answer immediately. So Dr. Aniket? We don't have time to think now.
Leptin, sir. Leptin.
Leptin. No, you read the whole question now, but the answer is already wrong, so it won't be making a difference. It's a 3-year-old girl with rapid weight gain, fairer compared to the parents, low cortisol, and a low ACT.
Sorry, sir. MC4R. MC4R.
Yeah. But unfortunately, we don't give up a second choice in this one.
Okay.
So, this was actually, if you had thought, you would have got the answer. MC4R receptor agonist, set melanocyte. But anyway, this was a wonderful effort by Dr. Aniket as well. So we have come to the end. While we compile the score, I think there is one final audience question. Blood sugar of 450 DK managed with insulin infusion in a newborn child, which clinical finding predicts transient form? We already discussed this, I think, just before that. So which finding? I think we'll see the audience. What are they saying? Set melanocyte already was answered. So it was, the audience are very, very reactive. So Dr. Shruti, umbilical hernia, omphalocele, ear creases, these are all like transient phenomena. So I think this was a wonderful interactive session. And by the time we come to the final scores, we have got Dr. Reshma, who has got the top score of 40. A big round of applause to her. The second position, there is a tie between, second position is to Dr. Guru Prasad, 25. So that's a clear-cut winner. Then there is a tie between Dr. Aniket and Dr. Manoj Reddy. Dr. Aniket lost 20 points actually in the last one. Otherwise, he would have won the quiz. So again, both the quizzes, the person who gave more answers. So again, as I said, if you run, then only you will fall. So that is there's no problem with that. I think that's the right attitude. And we have got Dr. Somaya and Dr. Arun both with 15. So I think this was a wonderful experience. Before we close, we'll take a feedback from all of you. Dr. Somaya?
Sir, thank you so much. This was like a great learning experience, sir, especially in pediatric endocrine, to get to know pediatric endocrinology better. So it was really wonderful. Thank you, sir.
Okay. Dr. Manoj?
Yes, sir. I learned a lot regarding pediatric endocrinology from your videos. And today I got an opportunity to learn some more points in pediatric endocrinology. Thank you, sir, for this platform.
Dr. Arun?
It was a very good experience, sir. Learned a lot of new things today from you, sir. As always, your quiz was excellent.
Yes, so quiz is basically meant to encourage knowledge. It's not like a competition because some questions you will know, some questions know, others will not know. So don't worry too much about all that. Dr. Aniket, you were doing very well, and then you got caught at the boundary line, I think.
Yes. Yes, but it was a great learning experience, and it is always a pleasure to interact with you. And this was one of the opportunity which I would never lose to interact with you. So that was very nice.
Thank you, Dr. Aniket. Dr. Guru Prasad?
Sir, as a general physician, you made me to appear for a pediatric endocrinology quiz. So the credit goes to you, and I always call you as an endocrine storyteller. Thank you, sir.
Thank you. And Dr. Reshma, finally?
Thank you so much. Thank you so much, sir. It was a huge learning experience. And I would like to thank Arun. He helped me like prepare what all to read. He was telling me. And Santosh sir, my teacher, he's
Santosh is here only. So you can come up.
Excited, I'm sure, more than me.
So Dr. Santosh is here only.